So we're a little bit over. I'll try to make this somewhat brief. I don't have too much to say because my title of this talk is Adjunctive Fasciotomy and the Management of ALI, Prophylactic versus as-needed basis. And I think that this really hasn't changed a lot in many, many years. You know, compartment syndrome is a pretty dreaded complication of our revascularization procedures. And I still think it's whether or not to do fasciotomies and how to watch for this is really a judgment call that takes a high degree of suspicion and expertise. Compartment syndrome is what we're trying to avoid with fasciotomies. It can occur from both open and endovascular procedures. There's two categories that cause this. There are traumatic injuries to the lower extremities, such as crush injuries, arterial injury, which basically requires revascularization, and then that leads to a period of ischemia and reperfusion. And that's what we deal with when we're doing embolectomies or bypass surgery, where we have prolonged clamp times, a period of ischemia, followed by reperfusion following the embolectomy or the revascularization. This can occur in endovascular procedures as well. There you can have an analogous traumatic situation. Arterial perforations can lead to hemorrhage into the compartment, a little bit different than the ischemia reperfusion that you get following prolonged sheath occlusion and FEVARs that take a long time, thrombolysis procedures for ALI, or even recanalizations. I've seen one patient with a chronic SFA occlusion, and after recanalization of that, he developed a true compartment syndrome from reperfusion, although that's pretty uncommon. Early signs of compartment syndrome are shown here: fullness and tenderness of the compartment. This is probably the most important one to pick up on and be attuned to and follow over time. If you detect tenderness and fullness in the compartment and follow that clinically, that's probably, I think in my mind, your safest way to avoid some of the complications that can occur. When you start getting pain that is disproportionate to physical findings, that is another sign. Once you start moving toward paresthesias, loss of two-point discrimination, and certainly when you get to muscle weakness or motor deficits, and definitely when you get to loss of pulses, you're really moving down the spectrum of having some clinical sequelae of compartment syndrome. So you really need a high index of suspicion at the earlier part of this progression, and you want to consider intervening around those times. Indications for fasciotomy are listed here: pain with passive flexion, once you get to that sensory or motory loss, limb ischemia for prolonged periods of time, which we can debate a little bit about that. There are some other traumatic issues like burns, and then elevated compartment pressures on Stryker assessment. This is something that there's no absolutes with this. There are some guidelines that we kind of look to help us make a clinical decision, but nothing absolute in terms of pressures. Late signs are what you see here. Again, the change in pulse exam, pretty late, paralysis, CK is going up. Once you've gotten here, you've missed the boat, and you have probably had some, at the very least, muscle injury, if not neurologic injury as well. So you kind of want to avoid diagnosing compartment syndrome with any of the things that you see here. In terms of compartment pressures, normal pressures are less than 10. Pressures done by placing a needle with a transducer into the compartment and monitoring the pressure through a pressure circuit. If you see pressures in the 25 to 30 range or above, this almost always means you have a compartment syndrome that requires fasciotomies or fascial release. It does not mean that if you have a less than 10 number, you've sampled the right compartment or you're free from concern, but it is reassuring. If you have low pressures, it should be alarming if there are higher pressures. Compartment syndrome is caused by the relatively inelastic connective tissue defining each of the compartments, the superficial and deep posterior compartments, the lateral and anterior compartments. When doing fasciotomies, once you've diagnosed compartment syndrome or you're concerned enough to do prophylactic fasciotomies, we typically do these through a two-incision approach is what most people use, with the lateral incision located over the septum between the anterior and lateral compartment. And this allows you to make an incision in each of these fascial components separately. You do need to watch for some of the vessels that go through there: anterior tibial artery in the anterior compartment, peroneal nerve controlling dorsiflexion in the lateral compartment. Lateral compartment is probably the most subject to compartment syndrome of the different compartments, and probably the one that we see the most common injuries of peroneal nerve injury. In terms of the medial incision, that gets you right into your superficial compartment right here, and then when you take down the fascial connection to the tibia, you get into that deep posterior compartment where the posterior tibial and peroneal arteries are. In terms of the question of should we do a prophylactic fasciotomy, there are some benefits to this. Muscle preservation. So the first thing you probably lose is some muscle tissue or develop some muscle injury. That's usually pretty well tolerated compared to nerve injuries. On the other hand, you can also avoid not only neurologic injury, but you can sort of sleep better at night knowing that you've protected yourself against a missed compartment syndrome. There are some times in mass casualty situations and war issues or sort of a domestic mass casualty where you don't have the resources to monitor patients intensely, and for those reasons sometimes a prophylactic fasciotomy is appropriate. Now there are some drawbacks. Obviously once you've dealt with a number of these fasciotomy incisions, patients do not like having large wounds on their legs. There's the pain and discomfort and the prolonged recovery they go through. You can have neurologic injury from injuring the sural nerve or peroneal nerve upon your actual release, wound healing issues, and then the need for repeated procedures, taking them back to the OR to close the wound, vac changes if you're going to manage it non-operatively, skin grafts, and increased length of stay. So there are definitely some drawbacks of these prophylactic fasciotomies. So getting the question, how do we decide between prophylactic or delayed or as-needed fasciotomies? I don't think there's a simple answer for this. Again, this is where clinical judgment really does come into play. Maybe the first thing is to sort of think about which patients are at risk for having a compartment syndrome, and that's probably where this question begins, or the answer to this question begins. This is a publication that looked at a 16-year period of time over 2 vascular interventions, about 700 patients who underwent thrombolysis for acute limb ischemia. 78 of those developed compartment syndrome. And when those were compared to the controls that did not develop compartment syndrome, there were a couple of risk factors that certainly came to light. More severe ischemia, so patients with Rutherford 2B ischemia, those are patients that almost certainly are at an elevated risk for compartment syndrome. Specific anatomic problems of occluded popliteal aneurysms, again, very high risk of compartment syndrome. And there are some factors that are probably associated, that not shown in this paper, but in some others, that are associated with high risk of compartment syndrome or conversely low risk. Patients with a larger volume of muscle mass, interestingly, are more likely, and there's at least one report showing that particularly women and people with very small muscle mass are maybe protected even in episodes of prolonged ischemia. So knowing which patients are at risk can help you make that decision about whether or not to go to prophylactic fasciotomies. One thing that is clear when we look at prophylactic versus delayed, in those patients who have delayed fasciotomies, who require fasciotomy but do so in a delayed fashion, more often than not, we've missed something in those patients, and that's the concern. So in this study of 138 patients revascularized after ALI, 42 patients had fasciotomy, and of those, 34 patients were prophylactic, whereas 8 were delayed. So in other words, they picked up findings on exam post-op that prompted them to go ahead and proceed with fasciotomy. This study showed that those patients undergoing delayed fasciotomy were more likely to require major amputation at 30 days. And look at the numbers there, 50% versus 5.9%, a tenfold increase. And so that is something that is somewhat alarming. And that was true in arterial trauma in the National Trauma Data Bank, 1,500 patients roughly of lower arterial injury. The same sort of finding, those patients that underwent, of those 612 that underwent fasciotomy, 88% underwent early or prophylactic versus 11% underwent late fasciotomy or delayed. The early fasciotomy was associated with shorter length of stay, lower amputation rate, a fourfold increase in amputation in those that were delayed. So I think this speaks to the danger of delaying our fasciotomies in patients who ultimately are diagnosed with compartment syndrome and require it, a potential for a missed compartment syndrome. So to conclude, compartment syndrome is a serious complication following lower extremity revascularization. Diagnosis continues to require a very high index of clinical suspicion. And an expectant approach to fasciotomy can certainly be performed in many patients with lower extremity revascularization, but when we delay and do it as needed, that has to be a really quick decision when those signs develop. Otherwise, I think we'll find what most studies show, which is an increased rate of amputation or neurologic injury. Thank you.